Hi, this is Karthik here, and thank you to the RISE team for the conference and for inviting us to present this paper. As I've said on previous occasions, I think the RISE conference is the highlight of the annual conference calendar for education in developing countries, and I'm excited to be presenting this new paper to you today. So let me share my screen. So this is joint work with Alejandro Ganimian at NYU and Chris Walters of UC Berkeley, and it's a paper on improving early childhood human development with a large-scale randomized experiment from India. So for those of you who are regular at RISE, I think the basic facts on developing country education are well known, which is that, we have made impressive progress in improving school enrollment and completion in the last 2 decades, but learning levels are still very low, with a large fraction of kids completing primary school without having basic foundational literacy and numeracy. So I think, one promising policy option for alleviating this problem is better early childhood education. So in particular, if you look at the pathway of expansion of education in developing countries, this is focused on starting in grade 1, which is similar to the OECD experience, reflecting a combination of lack of resources and capacity to also do preschool education, okay? But if the productivity of resources of school education is low because kids are not school ready, then the returns to early childhood education may be quite high. So I think there's growing policy interest around the world. It's there in India's new education policy. It's there in documents of the World Bank, that there is general consensus almost that early childhood education is an important investment. The problem is that the evidence we have to date on early childhood education usually comes from smaller scale studies with intense and high quality implementations, and we just don't have evidence yet as to whether it's possible to deliver improved early childhood education outcomes at scale. And so that's kind of the main focus of this paper, and we're working in the context of India's Integrated Childhood Development Scheme, the ICDS, which is the world's largest early childhood education program. It caters to about 36 million kids in the age group 3 to 6, and it's free and therefore disproportionately caters to the poor. The ICDS and the Anganwadi system, they provide a range of early childhood health and nutrition services in addition to preschool education. The ICDS has about 1.35 million Anganwadi centers, which is how the system runs, and their staff, they're staffed essentially with an Anganwadi worker who's responsible for both the health and the education services, and a helper who's responsible for preparing meals and feeding children and cleaning the center. So here's what an Anganwadi looks like. So this is a better equipped Anganwadi in Chennai, which is the capital of Tamil Nadu. If you go to rural areas, the physical infrastructure will be poorer, but the basic structure is the same, right? So here's the worker, this is circle time, the kids are getting ready for a meal. And so this is what an Anganwadi center would be like. Okay. Now, despite the importance, ICDS has limited staffing and funding, and in particular, a single Anganwadi worker is responsible for both a range of health and nutrition services, as well as preschool education, as well as home visitation programs, as well as providing supplemental nutrition and home-based interventions to children aged 0 to 3 who are not the subject of this study, because we're focusing on the kids who come to the center that's aged 3 to 6. But bottom line is that the time and motion study that we did as a pilot to this project showed that the typical Anganwadi center spends only about 38 minutes a day on preschool education, and that essentially that the single worker was actually quite overwhelmed. And so, and in addition, the Anganwadi worker salaries are much lower than those of civil service teachers, because the workers are hired locally in the same village, and the pay is about a third to a fifth of a regular civil service teacher. So Anganwadi worker salaries are about 8,000 rupees a month compared to civil service teacher salaries of 30 to 50,000 rupees. So it's almost a factor of 4 to 6 times higher. And so the combination of potential high returns and the low costs suggests that augmenting the capacity of these centers with an extra worker may be a high return investment. And that's exactly what we're studying in this paper. So based on our field assessment, as well as kind of understanding of the landscape of service delivery and state capacity in India, we recommended to the government of Tamil Nadu that it might make sense to add an extra worker to focus exclusively on preschool education. And the project was done as part of a larger MOU between JPAL and the government of Tamil Nadu, which is kind of a unique research policy partnership to conduct pilots of promising interventions in partnership with government departments to then see if that evidence could be used for scale-up decisions in different policies. So the basic contours of the program are very simple. It's the facilitators were hired on a 2-year contract, and the eligibility conditions were they were female, at least 18 years old, from the local community, and have passed a high school, past secondary school, which is grade 10 exams. Now, the government already had a curriculum in place, which had been designed in partnership with UNICEF, which included daily activities recommended for each day. It had manuals and trained facilitators and their expected division of labor. So, the bottom line is that this looks a lot like many settings where the on paper these programs look excellent, but the main gap is that you don't have the staffing or the capacity to implement these programs on the ground. So it's a setting where it's a direct intervention about augmenting state capacity at scale. Okay, so we drew a random PPS sample of 320 Anganwadi centers. So again, this is not like a small study done with NGO implementation. This was implemented by the government. Here is a map that shows you India. The southern state of Tamil Nadu is where the study is. The sample of districts is representative of the regions, north, central, south, and also spanning the nutritional attainment distribution. And so, yeah, so basically, it's a very simple RCT, 320 centers across these 4 districts, half treatment, half control. The randomization is stratified by district and a bunch of other demographics. The randomization is perfectly balanced. So basically, this is a classic example of what, Paul and I have written in our JEP paper on experimentation at scale. So it's done in a representative sample. It's got government implementation. And so that's going to extend the external validity of our results, at least to the entire state of Tamil Nadu. We collected data on child assessments, which is the core outcome, math, language, executive function, with a baseline and end line about 18 months apart. These are administered individually, orally in the local languages. Now, we do test the kids in both the centers and the households, and I'll come back to that in a moment. And then the one other set of outcomes we collect as a secondary set of outcomes are outcomes on child nutrition. So we collect height and weight with which we calculate an age. And so that allows us to calculate the height for age and weight for age Z-scores, which are the main measures of stunting and malnutrition. Okay. We have surveys of implementation fidelity. We have unannounced visits to the centers to measure attendance. And then we have announced visits where we sit there in the center for the entire 2 hours that are scheduled for preschool instruction and use a modified Stallings instrument to capture exactly what's going on within that 2-hour window within the classroom. Okay. So basically, the estimating equation is very simple. There's the outcome at the child level. You control for all the randomization stratification variables. You have a bunch of other basic demographic controls and an indicator for treatment. Now, the one tricky thing here is that so this is all straightforward. We also don't have any differential attrition, so that's completely fine. But there is a problem in that the follow-up rates in the Anganwadi Center are only about 33% in that 18-month period. And the reason for this is that kids' attendance in Anganwadis tends to be much less regular than in the regular school system. So because parents often treat this as daycare rather than education. And so sometimes if the parents are traveling or working or migrating, the kids will get pulled out. The kids will sometimes just drop out and not show up. Sometimes they will transfer to a regular school. They might accompany an older sibling to the regular school. They might go to a private school. So in that sense, the Anganwadi system, the adherence is not that high. And that's why what we did was we also decided to augment the standard center measurement with a household survey where we managed to track down close to 90% of the kids in the baseline. So if you look at the attrition, what you'll see is that in the Anganwadi center sample, the follow-up rate is 33%. In the households, it's about 89%. But there's no differential attrition, okay? So the experimental estimates are going to be perfectly valid in both samples. It's just that the interpretation is different. So there's no differential attrition. There's also no differential attrition by any observables. So we have additional tables of that. But the main point is one of interpretation. So you should interpret the results coming from the Anganwadi center sample as reflecting the experience of the kids who actively attended the centers over this 18-month period, and the estimates in the household sample as an intention to treat that's for the entire cohort that was potentially eligible, exposed to the treatment. Okay, so and both of these are going to be meaningful constructs. The results in the Anganwadi center sample speak to the impact on the kids who actually attended, and we'll use the household sample estimates for cost effectiveness because you can't you pay the cost regardless of whether the children actually attend or not. Okay, and so that gives us about 5 minutes for the results, and so everything was well implemented, so this was not a problem. So let's get to the main results. Okay, so the first is just looking at attendance. And so what you see is, as we've seen in other studies, so the first and second columns are the behavior of the Anganwadi workers in the control and the treatment centers. Okay, the fourth column is the ECC facilitator, and the fifth is the difference between the two types of workers. Okay, so the main thing to highlight here is that these ECC facilitators seem to be just more diligent, and partly maybe because they're younger and the nature of their contract is even more contingent. And so what you see is that the absence rates for these facilitators are about 20% lower. Now, to be fair, the Anganwadi workers also have other duties, including household visits and other responsibilities. So, this is not to imply that they were shirking, but they were certainly not at the centers. So if you just look at attendance at the centers, the facilitators are about 20 percentage points more likely to be there, and that's a big deal. Okay. Now, what's more important is the time on task in the 2-hour window that we go and actually measure exactly what's going on. So column 1 tells you what's going on in the control centers. Column 2 is what is happening with Anganwadi workers in the treatment centers. And so column 3 is giving you the treatment effect on the workers. Column 4 tells you what the facilitators are doing. And column 6 is adding what's going on in the treated centers because you've got 2 workers. And column 7 is the composite impact on time spent on each of these tasks. Okay, so so the first thing you see in column 1 is that your typical control center gets about 38 minutes a day of preschool education. In the treatment centers, the Anganwadi worker kind of cuts her time in half. Okay, so there is a reduction, but the good news is you get an extra 57 minutes that's coming from the facilitator. So you add the two together in column 6, you get about 76 minutes a day of instruction compared to 38 minutes in the control center. So that's a doubling of instructional time that you're seeing in the treated centers. Now, there's also an increase in administrative tasks. Now, basically what's happening is, and so here's why we think this might be a lower bound on the total productivity of this intervention, because the administrative work doesn't change across treatment and control, but it looks like what's happening is that the regular worker is spending this 2 hours in the classroom doing more administrative work and overseeing the facilitator who's doing the preschool instruction. And so if that allows her to finish the administrative work within those 2 hours, it may free up time for additional education activities or home visitations, things that we don't observe outside the 2 hours. But what you see even with the 2 hours is you see a near tripling in the time spent on health and nutrition tasks. Okay, so this includes everything from encouraging hand washing to I think making sure that kids are eating their meals properly. So, this is obviously within the time schedule for school instruction. So you're not seeing all of the impact, but even there, you're seeing kind of this near 10-minute increase in time spent on health and nutrition tasks, which is a near tripling of that time available. Now, of course, there's also increase in slack time. So there's more time off duty as well. So that when you have 2 workers, they're also chatting and talking. So, and this is consistent with other studies, that when you put an extra worker, you do get an increase in slack of the existing worker, but the composite impact is still a net positive on all of the key measures, that you get more time. So consistent with this, you see significant positive effects on learning outcomes. So in the Anganwadi Center test, you see a near 0.3 standard deviation increase in math scores, 0.45 in language, 0.18 in executive function, and a composite score that's based on a principal component is close to 0.3 standard deviations. Okay, so these are big numbers. So those of you, of course, who know, how hard it is to get meaningful treatment effects in education. And then, like I said, we also do the household testing, and and the estimates roughly seem to scale by about 1/3. And in fact, it's almost certainly driven by sample composition, because when you compare the household and center test for the same kids, the treatment effects look like what we're seeing in the Anganwadi center assessment. So the household effects are lower, mainly because it's capturing a bunch of kids who are no longer attending the centers. But from a cost effectiveness perspective, we're going to use the much more conservative treatment effect of 0.11 standard deviations rather than the more aggressive one of 0.29. So again, you should interpret the 0.29 as representing what happens to kids who are in the centers, and the household as the ITT for the entire cohort who could have benefited from the treatment. So this by itself is hugely encouraging, but not a total surprise given what we saw on time on task. I think the real surprise to us was we're also seeing substantial positive effects on nutrition impacts on the kids who in the centers, okay? So we see a 0.1 standard deviation, or 0.9 to 0.09 to 0.1 increase in both the weight for 8Z score, that's column 1, and the height for 8Z score, that's column 4. And a significant, like 3 percentage point reduction in the fraction of kids who are severely underweight relative to a 9% control mean. So that's almost a 1/3 reduction in severe malnutrition. And similarly, about a 2.5 percentage point reduction in severe stunting. So I'm out of time. And so let me wrap up in the last 2 minutes. So again, this is really, I think, quite important and gratifying, because we haven't even seen positive effects on nutrition from other studies we've done that explicitly focus on nutrition. So again, it highlights that the constraint in terms of worker time in the last mile is a really big deal, and alleviating that can give you these additional broad-based positive effects. From a cost effectiveness perspective, like I said, we very conservatively use the returns from the household estimates, and we kind of use the global literature. Chris Walters, who's one of our co-authors, has written a review paper based on US evidence, and basically using the best global numbers, and of course making some heroic assumptions, we still very conservatively estimate that the benefit to cost ratio is going to be about a factor of 12. And we do the sensitivity analysis to all the ranges of parameters, and basically, however we run the numbers, we end up with a 5 to 95% confidence interval of the return on investment of being between a factor of 5 and 25. So this is almost certainly going to be a high return investment. Okay, so to wrap up, the most important contribution is to show that it is possible to improve early childhood learning outcomes at scale, and to do so in a cost-effective way. Just for perspective, ICDS caters to about 50 times more kids than the well-studied, well-known Head Start program in the US. And, it just highlights again the importance of programs like RISE to increase the amount of research that's happening on these programs in developing countries that don't get nearly the same amount of attention, even though they cater to, many, many multiples of kids compared to much more well-studied programs. We contribute to literature on strengthening on interventions to improve ECE. Like I said, the existing evidence finds a lot of positive effects in small-scale interventions, but modest to null effects at a larger scale. And so we're providing direct evidence about the returns to strengthening public systems to improve outcomes at scale, which is again consistent with RISE, which is about research and improving systems of education. And I think more broadly beyond education, I think the results also speak to the returns to augmenting state capacity for service delivery through adding locally hired staff. So I think and I've done a lot of work on this in the past 2 decades on personnel economics in the public sector. And in general, what you see is that the government is massively understaffed, in part because the salaries are so high. And what we see from study after study is that this wage premium is not correlated with productivity. And so expanding hiring of locally hired staff at much lower than civil service salaries may be a promising policy option, both for augmenting state capacity and for kind of creating jobs, employment, and improving outcomes. So I have a whole policy paper on this, and that also talks about additional benefits, including female empowerment. And the last point is, I think the results also speak to the broader literature and the costs and benefits of occupational licensing. So a lot of the policy discussions on expansion of early childhood education stipulate that teachers should be formally trained and qualified. And our results suggest that such qualifications may not be necessary. Now, this is not to say that qualifications may not have additional benefits, but if you're going to hold back an expansion waiting for qualified teachers who then have to be hired in civil service salary scales, that may actually be quite suboptimal optimal given that you don't need to wait, right? The centers are open, they're understaffed, there's unemployment in the villages, and the locally hired staff with a secondary school education and just a week of training may be highly effective at improving early childhood education outcomes. And these results are consistent with what we've seen in school education. So let me stop there and thank you again. And I apologize for not being there in person for the discussion since I have another commitment, but Ale will be there and we look forward to all of your comments. Thank you.